symptoms exacerbated, and they went online looking for some remedies, and they tried some different types of oils, and I think also hydrogen peroxide drops from over the counter at the pharmacy, but to no avail. And in fact, if anything, their symptoms exacerbated because the oils had been absorbed by the wax plug and expanded and swollen. The best way to explain this compaction and impaction is if you're on the seaside and you've got your bucket and spade, and you use the spade, the shovel, to scoop up some wet sand and position it in the bucket, and then on the reverse side of the spade, hammer it in. That's how impacted this wax is. This is the left in. It's incredible how much wax I ended up removing, because the wax is actually impacted past the second bend. Therefore, approximately the ear canal length from the second bend to the eardrum is around, I would say, around 1 centimetre. And the amount of wax I removed, because it was impacted, it was the equivalent of removing wax from a non-impacted ear from the entrance all the way to the eardrum. I had to put some olive oil drops in, and I actually performed the procedure whilst the drops was in situ. When I first started putting drops in the ear, I used to put the drops in, let the drops penetrate for a few minutes before getting the patient to tilt the head in the opposite direction so I can drain it and then go back in. But more and more now, I'm actually performing the procedure whilst the drops is in the ear. Makes it a bit more difficult. So the patient's head's tilted over to one side, and I actually stand up when I do this now, so I can look directly into the ear. And because there's oil in the ear and you're suctioning, you do get a bit of blurriness as well, because the suction probe is suctioning the oil as well, and that can blur the distal end of the endoscope. Nonetheless, I've been doing it for a while now and feel really comfortable doing it. And I just think it has a better effect, suctioning whilst the oil's there, because the mechanical process of suctioning the oil will help also loosen this wax plug. Because you're suctioning the oil seeped in behind the wax. When you're performing suction, it's trying to suction the oil, and as the oil moves towards the suction probe, it's kind of dislodging the wax as well. So I've just got one plug out there. And you can just see how dark this plug is. It's been there for a while. It's oxidized, so it's matured in colour. Freshly secreted wax is a light brown shade, and as it ages and gets older and it oxidizes within the ear, it can turn to a medium brown to a dark brown and almost a jet black in appearance colour. The patient has got quite a pronounced second bend. So within the ear canal, there's 2 bends. The ear canal, the shape of it is like an S, like a snake. The first bend is about 0.5 centimetre within the ear canal. The second bend is a further 0.5 centimetre into the ear canal. At that point is when the cartilaginous portion of the ear canal and the bony part of the ear canal meet. So the outer third of the ear canal is made up of cartilage, it's flexible, it's semi-sensitive, whereas the inner 2/3 of the ear canal is made up of bone, and there's a very thin layer of skin that's tightly adhered and lines the bony part of the ear canal. It's less than 0.1 millimetres in thickness, whereas the skin that lines the outer third of the ear canal, the cartilaginous portion, is a lot thicker. That's about 1 millimetre in thickness. And the outer third of the ear canal, that's where all the hair follicles are. You shouldn't find any hair follicles located in the inner 2/3, the bony part. And it's these hair follicles that secrete 2 substances: sebum from the sebaceous glands, which are situated at the root of the hair follicle, and if you have the gene mutation, the ceruminous glands, which secretes an oily sweat. And again, the ceruminous glands are found at the root of these hair follicles. And the sweat, if you have that, and this fatty oily substance called sebum, it's the same secretion we have on our scalp, mixes with dead skin within the ear canal, and it amalgamates, and that's the recipe for earwax. So the majority of earwax is actually 60% of dead skin, whereas the remaining 40% is made up of the sebum. And as I said, if you have that specific gene mutation and oily sweat, the ceruminous gland, that's the gland that secretes that oily sweat. It's the same sweat gland we find under our armpits. So if you have sweaty armpits when you exercise, for example, it means that you've got this oily sweat gland within your ear canal, which will produce a more of a wetter type of earwax. Now, managed to remove that plug. There's a tremendous amount there. There's the eardrum. It's intact, slightly red, slightly inflamed because of the impaction, but you would have seen the front part of the ear canals slightly protruding, so the patient has got a bit of a pronounced anterior recess, a little cravat, a little trench. In the case of the left ear, on the left-hand side of the ear canal. This is the right ear. I went in straight away with the oil, given the impaction on the left. This came out a lot easier than the patient's left ear. I was just manipulating this out, so there's a big plug here. I think the patient had been using a bit more drops in this ear in the first instance, because when I go back in now, the wax is a bit more wet and slushy. It's probably the best way of describing it. And similarly, once I remove this wax plug from this patient's ear, you'll see the front part of the ear canal. There is a bony protrusion, so the anterior canal wall, which is the front part of the ear canal. So in the case of the right ear, it's the right-hand side of the ear canal. The bone just protrudes outwards and it goes back in again, which creates a recess, a little pocket, a little trench, if you like, a cravat, whatever you wish to call it. And when you use cotton buds especially, you can impact wax in that little trench. So it's hard to sometimes remove and dislodge. Some people don't have earwax, but they have a buildup of dead skin in the ear, and that's quite medial, so near the eardrum. So the skin that lines the eardrum, the epithelial layer of skin, as that dies and sheds, and it should migrate out of the ear naturally. So if we were to get a marker pen and make a dot on the eardrum, if we monitor that every month, on average, we should find that skin that the marker pen was on, as it dies and sheds, it should migrate at a rate around between 1.5 millimeters and 3 millimeters a month. And eventually, after 10 months or so, that black dot will no longer be present in the ear canal. It would have migrated out. So some people with the pronounced anterior recess or inferior recess, as the skin migrates, it gets trapped within the anterior recess if they have a really prominent one. So it's not earwax, but it's dead skin. Initially, I used to always think, oh, the patient's been using a cotton bud here, they've pushed this in, but with experience you realise it's not earwax, it's actually dead skin, and it's not the patient's fault. It's they've done nothing to cause that, it's just the anatomy of the ear. Just mopping up near the entrance, there's a bit of soft wax just on the anterior canal wall. This is the cartilaginous portion. I can put a bit of pressure here, as I said, it's semi-sensitive. There's a bit more on the right-hand side of the ear canal, so the anterior canal wall, which is a bit more sensitive. And I did hover over it, I got a bit of it out, but the rest of it would have been really uncomfortable for the patient. Bit of wax is good for you guys. So in all of the videos you'll see there's a bit of wax here and there. I always hover over. If it comes out easily, brilliant, I'll remove it. Otherwise we'll just leave it there. I don't want to graze the canal because that will be uncomfortable for the patient. Here's the patient's eardrum. No trauma induced by the use of the cotton bud. The patient was slightly worried that they might have perforated the eardrum. I didn't have